Sheffield service. I'm sure there'll be time for questions at the end of each of the sessions and then again afterwards, but can I ask people to keep their microphones muted if they're not actually speaking? And I don't see everybody on the screen, so if you do want to ask a question, if I could ask you to either write in the chat box or indeed raise a virtual hand. So thank you very much, and I will hand over to Andy. Thanks, Andy.
You're welcome. Okay, so let me just do the classic, try and struggle to share my screen.
Perfect, thanks, Andy.
Is that okay?
Yes.
Good. So I'm not sure that's the best view, but that's about as good as we're going to get. So I'm here for that Stakeholder Rehabilitation trial. But first, if you compare to cast your mind back, March 2020, there was an awful lot happening at the time for all of us. Just to provide a little bit of context, we were still pursuing herd immunity, or apparently pursuing herd immunity. US had just placed a travel ban on the UK. The Queen stopped her public engagements. Within the health service, we were rapidly reorganising our intensive care and all of our clinical services to cope with the expected surge, redeployment away from theatres and research, or in fact just to advice to shield at home for more vulnerable members of staff. And we got the first UK case, you can see on the graph here. The first UK case was confirmed in 31st of January. By March the 14th, the UK had 1,100 cases confirmed. And actually on 14th of March, for us in Southampton, and a lot of the experience, I'll refer to Southampton, but I understand this is a national call. We admitted our first ICU patient. So, no, I apologise. Okay, bear with me. I'm just losing my screens here. Nope. Let's escape. Sorry, you're going to have to bear with me because I'm having a bit of a problem with my screens. Can you see that again? Has that moved to the next slide?
It has. It has.
Thanks, Fran. Okay, now I know the system. Hopefully it'll work better. Okay, so that was the situation for us in March. But now I think you all work in cancer services, so I don't think any of you will, it'll be too much of a reach to try to cast your mind back to what it might have been like being a patient with a newly diagnosed or in fact a suspected cancer. What's become clear is what we know now is that up to about around 2.7 million people may have missed. We know that 300,000 fewer people.
Andy, I'm really sorry. Your voice is coming in and out a bit.
Yeah, I can hear quite a lot of interference on there. Is that better?
That's lovely, thank you. And if everybody else can make sure their microphones are off, thank you.
So yeah, so none of this is new to you guys, I don't think. 300,000 fewer people were than expected were referred under the 2-week cancer pathway. So that's 3 million delayed screening, diagnosis and treatment. Here at University Hospital Southampton, cancer diagnoses actually fell by 50% in March and April. And of those diagnosed 50%, we now know that only 25% actually attended the follow-up clinics. So really at that point, the fear of COVID was exceeding the fear of cancer. But the delays to diagnostic treatments were exacerbated. There were delays to treatment, surgery, research was discontinued, theatres were rapidly reorganised into intensive care, nurses and ODPs were retrained and redeployed. So the situation was bleak, and it must have been awful for the cancer patients. So there's where we were, but I've been asked you to talk specifically about going forward, about making steps forward and some positivity, which I think we can provide. So I'm going to talk about the COVID-safe prehabilitation trial, and I'll certainly look through that and go through a little bit of the science and how that's organised. But importantly for us, though, I think the SafeFit story has 3 really important messages within it that I want to share. And hopefully you'll find these thought-provoking and may even be useful, whether you're a researcher like myself or whether you're looking more about clinical practice development. I think these 3 particular elements have important lessons for us all. And that's the importance of developing and maintaining collaborative networks. Absolutely crucial, and that will become clear as I tell you the SafeFit story. Innovation, necessity really can be the mother of invention. And out of such a catastrophic situation, with some creativity, perhaps some serendipity, actually we may have come across a very important piece of the Prehab puzzle. And then disruptive thinking. There are other ways of working, whether it's research or clinical practice. We don't necessarily have to follow the established paradigm. And I think SafeFit is a really good example of this, and I'll explain a bit more. So, in all of the reorganisation back in March last year, what may have escaped your attention was that literally 2 days after the first COVID patient was admitted to Southampton ICU, we had to stop our large national, definitive, we hoped, randomised control trial. So sponsored by UHS, hugely supported by the Wessex Cancer Alliance. And we had to stop it. So most non-COVID research was stopped immediately. And this inexorable progress of cancer prehab towards adoption as business as usual, that was halted too. Now I work for Professor Sandy Jack. I manage her prehab trials, and at that point I was managing her WesFit trial. It was a 4-arm randomised control trial, care for patients awaiting major intracavity surgery with a prehab program of exercise or psychological support, or a combination of exercise and psychological support.
You emailed me last Wednesday.
And it used a very detailed assessment model. Sorry, I can hear some conversations.
Oh, you can. Okay.
So sorry, Andy. If I mute everybody, I mute you as well. So if everybody could mute.
So the WesFit model used a very detailed assessment using cardiopulmonary exercise testing and prescribed supervised exercise training. And actually, it could be that it was more than was needed for most patients. If you're taking an extreme example, but if you're a 45-year-old triathlete awaiting hemi colorectal cancer, apart from being desperately keen to know what your VO2 max may be, for a clinical service, WesFit may just have been too much. So the primary outcome for WesFit, which was demanded by commissioners, was to prove effectiveness. By March, we'd recruited 236 patients across half a dozen sites. But at that time, I went back into full-time clinical practice, and Sam Leggett, who's our senior project coordinator, she was redeployed to run the Trust's COVID trials. So it really largely left Leslie Hawkins, who's now our senior project manager, and Sandy Jack. They had to phone round the patients on WesFit who had been listening to all of this COVID news develop and this reorganisation of cancer services, as I've described. And they had to ring every one of these patients and tell them that actually we were now withdrawing this supportive preparation that they'd signed up for and that we'd promised them. Sandy, I know lots of the patients were asking, what's happening to my surgery, what's happening? And of course, we didn't know. We had to tell them we had no influence over that. The patients were remarkable, but I think for those of you who know Sandy, it won't have escaped your notice, she does not lack passion, for sure, but I think this really lit a fire. And there was just this remarkable rapid implementation moving into a COVID-safe prehabilitation trial. So here we have a bit of a timeline. We got the first patient in Southampton ICU on the 14th. WesFit's paused. We have a week of phone calls, withdrawing the support from the cancer patients. On the 23rd of March, Sandy spoke to June Davis, who's Director of Allied Solutions at Macmillan, long-time collaborator and champion of prehabilitation, as is Fran and everybody at the Wessex Cancer Alliance. And they all got together over the ensuing week. And on April the 1st, work on SafeIt began in earnest. So this is very, very quick. And SafeIt is really only offering the support to the patients that we are today so soon after inception at such a pace because of the involvement of each of these groups. It is essential, and it's really the first point of major learning. It's collaboration, and these relationships with Macmillan, Wessex Cancer Alliance, these really predate SafeIt by some period. And actually, just as COVID may well have exposed structural defects within society, within the economy, within the health service, equally it shone light on structural strengths. And for us, these long-term established collaborative relationships reveal this absolutely essential components of the researchers' toolkits. And I would also say, as a clinician myself, as the clinical toolkit. So it's incredibly important. And we want to thank everyone who's involved in this. So what is SafeIt? So in essence, it's asking a very, very simple question. Can virtual clinics, exercise, nutrition, psychological well-being, deliver interventions which will support and improve the mental and physical health of patients living with cancer? And of course, it's COVID safe. So we've moved beyond our strictly perioperative studies, which is where we started, to all patients with a confirmed or suspected cancer diagnosis. Patients sign up via our website. There's the link up there for a nice plug. And what's important about that, regarding sort of disruptive ways of doing things, there are no clinician referrals required. Patients are sharing this information via WhatsApp groups, Facebook groups, various other different patient support groups, or seeing it in the lay press and signing up. For us, that means there's no setting up of separate sites. Ordinarily, for a clinical trial, an intervention clinical trial, you have to go to each individual R&D for each individual hospital and go through a contracting process, which Leslie takes care of, but is long and protracted. And we've got none of that. So we've managed to be really light, really quick and fast moving. Once the patients sign up, so self-refer, we undertake a screening call with them. It's structured. It's a safety mechanism. We look at their PAR-Q, so the patient physical activity readiness questionnaire, a nutrition questionnaire, and the psychological distress thermometer. If there's any positive scores on those or any uncertainties, the patient's case is presented to our clinical advisory group. So we meet every Thursday morning. It's chaired by Sandy. It's got myself in it, Professor Anna Campbell, who's a physio, Joe Murphin, who's cancer CNS at Southampton, and clinical leadership is overseen by Denny Levitt, Professor Denny Levitt, who's our local PI for the trial. So we take safety very seriously. If they pass that, then the patients consent, and then they're matched to a CAN rehab instructor. So CAN rehab, many of you will be familiar with, is a third sector, charitable sector exercise, cancer exercise specialist group run by Professor Anna Campbell. And they have an infrastructure that we've really matched up with and couldn't do it without. So once eligibility is confirmed and the patients pass the safety screen, they complete online consent and they're matched up with a cancer exercise specialist. They're all exercise specialists. They're level 3 reps trained. They've had additional training and support delivered. We've developed a package which is our sort of SafeIt package of training for the CAN rehab instructors. And then really we just match the patient and their instructor together, and then they coordinate when will be mutually convenient times for them to meet online. They get 23 sessions. It's all front loaded. So they get 3 sessions a week for the first 4 weeks. Then it goes to 1 session a week for 2 months, and then 1 session a month for the last 3 months. The idea being is that 6 months after the end of the intervention, what we're hoping to measure is improvements in physical and emotional well-being, because the patients have changed their activity and their behaviour by themselves. So it's a supportive self-management. It's entirely consistent with a long-term plan. Heavy emphasis on behaviour change and supported self-management. And we'll see how it goes. The exercise, the emphasis may be on the exercise. There's a bit of Joe Wicks that's going on in the first instance. The patients and the rehab instructors are doing exercises together, but there's a lot of goal setting, there's a lot of signposting as well, particularly in the nutrition and well-being side of things. So it's a really interesting. The outcome measures. So the primary outcome for people who are really into research, physical emotional functioning, measured by the EORTC, and that's at 12 months. And we've got a range of secondary outcome measures around nutrition, physical activity, traumatic stress, which we know is an issue and may well be more of an issue for patients who've developed a cancer diagnosis, certainly during COVID, and then obviously 12 months survival. And so this is a really key piece, I think, for anybody who's interested in prehabilitation for cancer, which I suspect there isn't a lot of equipoise within this group. So this is about innovation, necessity being the mother of invention. So most of you, I'm sure, will recognise the personalised prehab care pyramid. This is just lifted from the Macmillan Royal College of Anaesthetists NIHR prehab guidance, which in turn is adapted from the long-term plan for personalised care. Now, at UHS, we've had a long existing and very successful surgical school for those awaiting cancer surgery. Many of you will know Imogen Fesher-Jones and Denny Levitt. So really, this is targeting anybody with cancer. And we think that may be 40 to 50% of the population who appear, those who are relatively well, don't have any particular comorbidities, and really, may need some exercise advice, diet, smoking cessation, very easy light touch prehabilitation. WESFIT. Now we think WESFIT was labour intensive, and it may actually be unnecessary for a full clinical service. Every 3 weeks, these patients were coming in and getting cardiopulmonary exercise tests, exercise prescriptions, supervised one-to-one exercise sessions. And actually, that's probably more applicable for this very small group, 5, maybe 10% of patients for whom have really complex, acute chronic needs, highly deconditioned. Those at the top of the pyramid who need specialist help. And actually, this serendipity element of it, for COVID, the actual nightmare it was for people living with cancer. Some positivity may have emerged because just with some inventive thinking, we've got SafeFit, which is that covering that middle piece. It's a relatively light touch intervention. It's online. It's using digital platforms. So it may be that actually through necessity of COVID, the mother of something really innovative and something really inventive. And so here we are. So BP, I'm calling BP is before Prehab, right all the way through to as we emerge and evolve through to a commissioned service. Could it be that SafeFit is the missing link? Really, time will tell. We hope so. So where are we today? So if I just continue, if you will, for a moment, the protocol was developed was delivered on the 13th of May. On the 20th of May, we submitted to REC. We got approval on the 21st of May. I say we, I was elsewhere at the time. This is Sandy and Leslie largely. We got R&D approval on the 26th of May, and we recruited our first patient on the 29th of May. So that's 16 days after the protocol was completed. And just 2 months after WESFIT was stopped. Now, when you consider the average time taken to recruit a patient for a normal clinical trial is well over 18 months, this is remarkable. We've recruited our 500th patient on the 1st of April, and on the 1st of April this year. We've trained 80 CAN rehab trainers, so thank you to Anna Campbell for that. We've recruited 522 patients as of today. Thank you, Leslie, for the very up-to-date stats, and we've had no safety events. So in a 12-month period, while the majority of clinical trials and our own previous clinical trial would still have been languishing somewhere between finding funding and protocol development, we've recruited and supported 500 patients to date. It's about disrupting this traditional way of doing things, and this is what it looks like. You've seen this slide or variants of this slide 1,000,001 times before. But I just think the creativity and the innovation that's come out of COVID, if you look at the recovery trial and if you look at SafeFit, and I do put those two together, we're just not accepting the usual paradigm of the research process. So through combined effort, collaboration, innovation, disruptive thinking, could it be possible we stumbled across a model for prehabilitation that will work and go forward to be a fundable clinical service? It fits beautifully within UHS. We're just developing currently a nutrition, exercise and wellbeing centre, supporting cancer survivors wherever they are on their treatment life course, from prehabilitation right through to response to the interventions that they're getting, the medical interventions right through to the recovery phase as well. And perhaps this sort of model is the one that will really work and take it forward. So just to finish my talk, I just want to summarize the main learning points so far from SafeFit, and I want to leave the final words with three great philosophers. Why not? Let's be bold. First of all, innovate. You know, Plato in Republic in 375 BC, he was the first really to talk about necessity being the mother of invention. He called our need will be the real creator. Excuse me. Disruption, new ways of thinking. Clayton Christensen, who was a very eminent scholar from the Harvard Graduate School of Business, wanted to generate new ways of doing business. He talked how it could be cheap, how it could be simple, and how customer demand may outpace system response. And I think SafeFit is a really live and fast-moving, good example of how that happens, and how eventually we hope the system may catch up. We'll see. And really, the very final word must be collaboration. We had established relationships with the NIHR, Macmillan, Royal College of Anaesthetists, and crucially with the Wessex Cancer Alliance. Thank you, Fran. And so I've got to leave the final word to another of our great late 20th century philosophers and poets, who really sums it up and needs no introduction from me. So thank you very much. Okay.
Brilliant. Thank you so much, Andy. As you know, SafeFit and WestFit have been really dear to my heart, but I have loved the fact that SafeFit has been offered across the whole of the pathway. And certainly from the Alliance's perspective, wanting it to be, we are looking at how we can hold on to that sort of universal plus bit as we move forward, and you guys look at different areas. Any questions? I'm sure people must have questions for you. I'm sure you can see the comments box where you're getting lots of brilliance and others. Any questions at the minute? What I did find interesting right at the beginning of the trial, though, Andy, was when and the importance of that collaboration, and the fact that, you know, your relationship management with mega organisations is so good, and how important it was to have them at the when COVID hit. But I know at the beginning when we worked with Macmillan and the platform was on the Macmillan website, we were looking to open it up to people who didn't want to be part of the trial as well, and that they would just go for the service. But we found very quickly that, or you found very quickly, that actually you needed the governance of the trial team behind you. I don't know if you want to add anything to that comment there.
Yeah, so it was, yeah, so I think that was quite difficult. So it was about translating research with a clinical service, and that's a very difficult thing to do, because you have, in some ways, you have different masters between the two, and certainly different ways of doing things. And I think trying to manage both actually threatened both slightly, you know. So what we wanted to do, you know, we ended up having a pause. I referred to this sort of research governance period.
We've lost your voice.
I'm on mute. Can you hear me again? I am.
Yes, I can hear you. I can hear you, Andy.
Oh, Sounds like some people can hear me.
You might need to respond to some of the comments in the comments box, Andy. I don't know. I don't think I've muted you.
Some people are saying they can hear me.
Yeah, that's good.
So I'll just say that actually what we realised quickly, we didn't want to threaten both of those outcomes, and actually the research had to take the priority. It had to be a research project that stood by itself, because the commissioners have told us very clearly that they want really firm evidence from robust clinical trials. Otherwise, what risks happening is that they've told us this, that you get sort of local services springing up, supported by incredibly enthusiastic and eminent local clinicians, but they wanted us to concentrate on getting the hard evidence. So we had to take a step back and make sure that we really just focused on getting that evidence, that scientific evidence, and that's why we did that and removed that clinical service element of it.
Absolutely. Zoe's hand was up. So do you want to ask your question?
Hi, Andy. Yeah, hi, Andy. I mean, that was just a fantastic presentation, and it is absolutely amazing to consider what has been achieved in such a short amount of time. I just wanted to ask about how you manage kind of going back to clinical teams. For example, understanding you've got patients from different parts of the country at different stages in their pathway. So if you're trying to escalate any clinical concerns or get more information about a patient to be able to offer them that kind of personalised care, how that's managed?
Yeah, so that's largely done through the clinical advisory group. So we when we do the initial screening, and remember it's very structured, we're listening out for the red flags. Yeah, I'm a little bit more breathless, or I get checked, whatever, or I've had Herceptin, or various different triggers that may make us concerned about the safety element of it. Those patients are all presented with a really low bar to the clinical advisory group, where we decide on how we respond to that and which clinician we will ask. So if it's a cancer specific question, we'll ask them to go back to the CNS often, or to their oncologist. If, for example, they're a lady with breast cancer who's had Herceptin and has had multiple echocardiograms, we'll ask for the reports of those and we can review those. So it really is personalised. Sometimes it'll be a GP, because they can be anywhere on the survivorship pathway. They may not have direct access to clinicians within the hospital with the detailed assessments, so we'll go back to the GP. And I would say, of the 500 odd patients, who I think probably somewhere like 30% have gone through the clinical advisory group, we haven't had any problems. We really haven't. The clinicians have been wonderful. They get back to us very quickly. One of the key things is that they're responding to a request from the patient. So we will ask the patient, look, please, can you go to this person and ask this question? And we're very specific. And I suspect that really aids the communication. And actually what's ended up happening, what we're realizing is that those clinicians are then going on to say, well, hang on a second, can I refer you someone else? Can I refer these other patients? And we've had groups from hospitals contacting us and asking for the referral, So it's blowing up, and the relationship's been very good. I can't fault it.
Thanks, Andy. I'm conscious that there are a lot of questions in the comments box, but it's also nearly past. Are you able to stay for the full hour? And if I hand over to Liam for his presentation now, and then perhaps you could sort of look at some of the questions, Andy, and we can come back to you at the end. Does that work?
Yeah, that's okay. Yeah.
Brilliant. Could I ask you to stop sharing your screen? Thank you very much. And Liam, are you happy to share your screen now?
Yeah, can everyone hear me?
I certainly can, thank you. So good. Can I ask you to introduce yourself and then talk about the Sheffield service? There is a hand up. Okay.
Hello, so I'll make a start then. Good afternoon, everybody. So my name is Liam Humphreys. I am a research fellow from the Advanced Wellbeing Research Centre at Sheffield Hallam University. Today, I'll basically be telling you about from an interesting position where we are just started the process of setting up our cancer rehabilitation service in Sheffield. I've been sort of taking notes as Andy's been talking, because obviously he's got lots of learnings that we can sort of take in. I've just seen Zoe on the call. We've already bothered her a couple of times asking different questions to try and find out what other people have been doing to set up such services as well. So recently, Yorkshire Cancer Research agreed to fund our programme for the next 3 years. And in this presentation, I would like to take you through our process of designing the programme and also what our model looks like at the moment. So in terms of the presentation, we'll go through our vision and aims of the service, the process that we have taken to design the service, and the infrastructure that already exists in Sheffield and how our model will fit within that. I'll talk you through the Advanced Wellbeing Research Centre and the facilities that it has there, and also the partners that we have involved in the delivery. And then we'll go through the planned service and ultimately what phase we're at in terms of the implementation at the moment. So our vision is to design, deliver and sustain a comprehensive rehabilitation service for people affected by cancer. Initially, that will be across Sheffield, but then ultimately we would like to move across South Yorkshire as well. And the aim is to embed physical activity within the cancer care pathways and create a unique, high quality rehab service for people living with cancer in Sheffield and South Yorkshire. And physical activity will be at its core, but will also have additional psychological and nutritional support as well. So in terms of this area of work, we've been working in this field specifically for designing physical activity services for people affected by cancer since about 2014, when myself and the team did the Survive and Thrive project, which was funded by the Western Park Cancer Charity, which was a qualitative research project which was interviewing patients and also health professionals in what are the sort of critical factors necessary to deliver a physical activity service or referral service for people affected by cancer. That project led us to do the Active Everyday project, which was funded by Macmillan between 2015 and 2018. And following that project, we were funded for a year to do a scoping project again funded by Macmillan to sort of scope out the appetite, I suppose, for prehabilitation with Sheffield and how that model might look.
Liam, sorry, is it possible to make the slides a little bit bigger, people are asking, and also not sure if they're moving on?
Oh, okay, they are on my screen. Bear with me. So is that any better?
That's brilliant. I think, yes, that's great.
Right.
Hopefully everybody's happy with that. Thank you.
Apologies, everybody. So we got to this one. There was nothing much on the other slides anyway. So in terms of the PrEP project, so it was about stakeholder engagement. So the stakeholders included health professionals involved in medical treatment for care of people affected by cancer, professionals involved in the provision of physical activity, nutrition and psychological support, and also people affected by cancer involved in the discussions. And we also held discussions with sort of leisure providers as well across the city. We also visited prehabilitation and rehabilitation projects around the country. One of my colleagues visited Westford, for example, to have a look at the sort of work that they've been doing. We visited the Prehab for Cancer and also the Prep Well, which is up in the northeast as well. In terms of the discussions that we had, the service initially set out to be solely prehabilitation, but from discussing with stakeholders, it felt that the prehabilitation is great. It's only one part of a rehab continuum. So we would like to develop a prehab pathway, but it also must lead on to rehabilitation as well. It's better to have them both together to have a fully comprehensive service. It should always incorporate a holistic approach. So patients should have access to exercise, nutrition and psychological support, which also came from the prehab guidance developed by Macmillan. And the referral needs to be quick and straightforward as well. So no onerous sort of form filling and access needs to be quick to get patients through. And we also looked at how the pathway should take place outside of the hospital as well, preferably in an area that has public transport access, but also ample and free parking as well. So all these different aspects were taken into consideration when we were developing the project idea. So in terms of the infrastructure within Sheffield, we have the Move More strategy across the city, which is a whole system physical activity strategy, and our rehab service will sit at the heart of a broader approach to create a culture of physical activity across the city. Move More is championed by the National Centre for Sport and Exercise Medicine, which includes the voluntary sector, the NHS, University of Sheffield, Sheffield Hallam University, the City Council, Chamber of Commerce, and also the leisure providers as well. And the whole idea behind Move More is the plan is to transform Sheffield into the most active city in the UK, and utilising sort of physical activity as medicine is a crucial part of that aspiration. So our programme is designed to sort of fit within this strategy across the city. Also within that, we have within the Move More, we have Move More centres, which are situated around the city. So it's 3 Move More centres, and they aim to connect healthcare with exercise as part of a patient's recovery or rehabilitation. So the Move More centres include NHS clinic rooms, education and training facilities, alongside the exercise facilities at a leisure centre or leisure site. So it's all on the same. So the aim is to sort of bridge that gap between healthcare and exercise provision. And the centres provide the opportunity for us to co-locate. So the idea is to run clinics within these facilities. So you can have patients, researchers, clinicians, sport and exercise medical specialists, and also public health professionals, all housed in the same sort of centre. And these are positioned across the city as well, so cover north, south and west as well, and have ample parking and excellent sort of public transport links. All the centres are modern and have state-of-the-art sort of clinical and leisure facilities. And so the idea is that together with the AWRC, which I'll talk about in a second, it creates a perfect sort of hub and spoke model for us to deliver a service for patients across the city. So this picture here shows the Advanced Wellbeing Research Centre, and the idea, the vision for the AWRC is to transform lives through innovations that help people move. And the mission is to help prevent and treat non-communicable diseases through co-design research into physical activity. If you know Sheffield, it's located on the Olympic Legacy Park, which is where the Don Valley Stadium previously was. And it's a research hub for physical activity research, really. And this opened in January 2020. And I think I worked there. If I say I work at the AWRC, I worked there for like 6 weeks before it closed due to the lockdown. And so hopefully soon, sort of September time, we'll be opening back up again to sort of get these sort of projects up and running. And the AWRC, like the Move More centres, has the clinic rooms and physical activity space, and also has the parking and the public transport access. And it's also situated in an area called Darnall, which is one of the most disadvantaged areas of Sheffield, which has high rates of mortality and adult and child obesity, which is a substantial cancer risk factor, and that's compared to the UK average as well. So it's an excellent location for such a hub. So in terms of partnerships that we have developed so far, there's one I've just noticed I've not added on here is the South Yorkshire Cancer Alliance as well. But we're working very closely with Sheffield Teaching Hospitals, and one of the part of the Sheffield Teaching Hospitals is the Western Park Cancer Centre, which is a world-leading reputation as centre of excellence for cancer care. And we've also made contact. I had a meeting earlier today actually with the different leisure providers as well across the city, which are helping us sort of like to fit into their current models of exercise referral. And our aim also, Andy mentioned the CAN rehab projects, is to upskill instructors into being exercise and cancer specialists to increase the capacity for people affected by cancer that can be actually seen and gain support. So I've been through, it's quite a long-winded way of going through how we set up the program, but here is just a quick look at the program that we are planning to implement. So like I mentioned before, it includes physical activity, nutritional support and psychological support. And the referral pathways will be designed to identify people who have been newly diagnosed with cancer to ensure support is available at the start of their journey. And that support will then span across the rehabilitation continuum. So from prehab through to restorative and supportive rehab after treatment. Our aim, though, is to have the service to be fully integrated within the cancer pathways by the end of the 3 years. The primary route of referral would be from a health professional. From our previous work that we've done, the most likely referral would be the clinical nurse specialist, the CNSs. And initially, the service will accept referrals from lung, colorectal and upper GI cancer as well. And then that'll be for the first year to 18 months. And then following that, we'll then start opening up the service to include referrals from other cancer sites as well. And then once a referral has been made, the person will be contacted and booked into a rehabilitation clinic to avoid dropout. And also because of prehabilitation, we need it to be started as quickly as possible. Excuse me. So here's I hope you can actually see it, because it might be a bit smaller on the screen. So here's a quick look at the model that we are looking at. So you see the different phases there. So we've got prehabilitation, maintenance, restorative and supportive rehab. So the length of the prehab period will vary dependent on the patient's treatment plan, and any subsequent physical activity prescription will be determined on an individual basis for that person. The intensity of the exercise would need to be sufficient to ensure that there is a physiological change to their fitness, and exercise intensity will be individually tailored dependent on their aerobic capacity. We may use high intensity interval training or similar if it's deemed appropriate, and we've stated at this point that the minimum period of 2 weeks for the prehab, and that was from the Prehabilitation Evidence and Exercise Review in 2018, as the minimum period with which we think it's feasible to make some degree of change. And the service will also deliver and align with the cancer waiting times as well. But in contrast to the prehab phase, which will be quite prescriptive, further down, so into the sort of maintenance, the restorative and supportive rehabilitation, that will provide exercise prescription will be more personalised to the patient and in terms of their preference. This will be to look at physical activities that will be more likely to lead to long-term behaviour change. And what I mean by that is, for example, not referring everybody to gym-based exercise at this point, when, as most people know, that gym-based exercise is not for everybody. So there will be about signposting to other options as well to ensure that it results in long-term behaviour change. So this is just a quick look at our risk assessment. This does need to more detail added to it, but if we take physical activity, for example, this is sort of based roughly on the pyramid that Andy showed earlier. So this would be their risk will be determined for physical activity will be on their fitness levels. So if, for example, they are deemed to be low risk, and they are that, which means they are quite already got a high aerobic capacity, then their exercise, they would be given sort of gym-based program with a level 4 cancer instructor, but also just told to continue as they are, because they seem to be doing well in that area. Medium risk, they'll be supported one-to-one by a level 4 cancer exercise specialist. If the small population that was at the top of the pyramid that was shown before they'll be supported by specialist rehabilitation physiotherapists to ensure that they get the best support for that person. So, and then we have the different sort of measures of risk for nutrition and psychological support as well. And IAPT, if you're wondering what IAPT means, that's improving access to psychological therapies, which is a service that's available to patients in Sheffield. In terms of our implementation phases, so we are currently, we started the project setup in March this year, and that will be going on for approximately 6 months, and then we'll be doing a sort of beta test of the referral pathways, which will start in October. Then ultimately with a hard sort of launch for the service in January 2022. And then after a year, that they will start opening to other cancer groups in January 2023. So that's our plan at the moment. So we're currently in the stage of recruitment for our programme, and working with the clinicians and also project governance within the Sheffield Teaching Hospitals as well. So there's lots to do, and there's a long way for us to go, but it's certainly positive, and we are making good progress with that. So I've gone through that quite quickly, but that's all for me. So thank you for listening, and if you have any questions.
Brilliant, Liam. Thanks so much. And yeah, really excellent. And many congratulations, which I know have come from a few people on the comments in terms of accessing the funding. Can you see the meeting chat? I'm just picking up. So there's Zoe again feeding back on. So is there anything you want to sort of pick up on from your side with Prehab for Cancer?
I was just going to say, I think it's just absolutely fantastic, Liam. I mean, when the news went on Twitter about the service, I think everyone in the Prehab community were very excited for you. All I was going to ask is just whether there's any specific research studies that you've got planned. I know there's kind of broader ones, but in terms of with the service, because obviously with it being very much based within Sheffield Hallam University and within the Advanced Wellbeing Research Centre, whether there was any specific studies, or are you going to get to that once you've got the service up and running?
I think we're most likely going to be the second option, so we'll get to that once we're up and running. But the idea, because this is specifically a service, so this isn't a research project, but our plan with that is to sort of wrap research around that, so bring sort of research questions from the work that we are actually doing, and I suppose it's sort of research in the real world for want of a better term. So that's the plan for that, and we do have a team of research at the AWRC already who are coming to me with work that they would like to do and the questions that they would like to look at as well. So yes, that is certainly part of the plan that we'll be doing. Yeah.
Brilliant, thanks. Hilly's just asking about how would identifying need relate to HNAs, the holistic needs assessments?
There's a question that I don't actually know. That's one thing that we do need to look at when we're sort of setting up these pathways, is how it links in with all these different existing bits that they have going on within the pathways. And the holistic needs assessment is one that we need to look at and speak to as well, to make sure that these are options on there, that people that it can be a sort of seamless link between the options. So yes, that's the discussions that we'll be having shortly. Yeah.
And Andy, I don't know if you wanted to come back in, because I know it was surprising when SafeFit went live, we expected people to be low level need as defined by HNAs, but actually they were identifying at much a higher level, and it's that balance between the HNA information, isn't it, and also patient activation, because there must be, certainly from the self-referral, patients will need to be fairly highly activated to be able to do that. I don't know what your two thoughts are around that.
Yeah, I mean, that's certainly true. We know with one of the main sort of methodological issues with the self-referral is that you've got highly activated patients who are coming into the trial anyway. Whereas, perhaps those harder to reach groups who may actually have more need are unlikely to self-refer. So it's actually essential, like a service like Liam's gets set up as well to gather the evidence from a broader clinical perspective rather than purely a research. And I thought actually there's some, so the Medical Research Council, the MRC, are about to release some updated guidance on evaluating complex interventions. And they take that all the way through from a feasibility trial all through to implementation science of a clinical service. I think that would be something, because there's lots of advice in there and about evidence that commissioners will take notice of, and I think it's very important. We're consistent with that.
Absolutely. Liam, did you have to do anything in particular to get the IAPS to pick up support for cancer patients? Because I think everybody has different experiences of referring into the IAP teams?
Yes, these are discussions that are still going ahead, but they are starting to do sort of group work within the Sheffield model. But I think one of the drawbacks a little bit of it is they try and encourage self-referral from the person to refer into their service, whereas we would like a more sort of direct route if there's any problems that we can refer them straight away. So these are sort of discussions that we're still having to make that sort of pathway sort of seamless.
Excellent. And Andy, how did you find that in terms of referral into services?
So we're not directly referring in to IAPT in the sense that we've got, for our psychological support, we've got an algorithm that we did design with psychological services in mind, and that ranges from referral to existing resource, for example, among others, the Macmillan website, through to recommending that the patient refers themselves to IAPT. Because remember that we don't have the same geography as Liam, so his are all local patients, and presumably you can just develop a relationship with your local IAPT service, whereas our patients are referring in from all over. So we don't have that relationship. So we haven't had yet any feedback from the patients about how easy access has been to IAPT. And then in the extreme end, we've got real safety concerns, and it may be that we have we've given asked the instructors to make 111 or even 999 calls if there's real sort of psychological distress. Yeah, I can't speak as yet.
Okay, brilliant, thank you. Liam, somebody's wanting your Twitter handle, if you could maybe find you on Twitter.
Yes, I wouldn't recommend following me. I'm not that interested on Twitter, but but our program, we are literally at the stage where we are just about to name the actual project, and then we'll be developing like our Twitter handles from there. So that will be another area that we will need to do in the near future as well. Yes, so, but I could put it in the chat if people want to.
Would you? That would be brilliant.
Yeah.
And then somebody else is asking, is this purely operation? I don't know. Is this purely opt-in, and what percentage do you feel the split will be for the universal and targeted?
We're currently, our discussions with the different pathways so far are that they want to, or they've called it opt-out, so the person is going to be referred unless they specifically say that they don't want to be referred. So in terms of the percentages, I'm not too sure at the moment, but we're hoping that will result in much higher sort of level of people attending than because for previous projects we left it sort of open, so it was up to health professionals to decide who they thought would be appropriate, and then you sort of, I think you do miss out on quite a large population of people that would benefit, and also you get people then that they sort of use their own sort of filter within their, like, sort of subconsciously of who they think would benefit from exercise, when even if it's quite low level exercise, people would probably benefit a little.
Okay, thank you. Northern Ireland seem to be very jealous of both of you so far, but I'm sure and I will get there as well. And June's just asking you, Liam, about the training needs of instructors. Have you done anything?
That's a conversation I was literally just having half an hour before this meeting, was with the local leisure providers, where we're looking at upskilling their instructors. So our previous project, the Active Every Day, did the same thing, which was train instructors using the CAN rehab course to make sure that to increase the sort of level of capacity within the system. And we'll be doing the same thing this time as well to ensure, because they have got quite a lot of instructors at the moment that are at level 3, but then to push them through to level 4, they would need that course. So yes, that's something that we'll be looking at. And the plan would be to link those people with sort of physiotherapists and occupational therapists as well to ensure the sort of like the proper upskilling of skills and in this area as well.
Excellent, because I think Holly earlier on was asking about the difference between a level 3 used in Safe Fit and the level, I think she must mean full cancer exercise.
Yes, so level 3 is the GP referral, so they can do more like a general sort of working, but then as you go to level 4, that is when it's you work in sort of like, you're now a specialist instructor. So there's level 4 courses now for example, for neurological conditions. There's level 4 for cardiac rehab, cancer rehab. So that means that you'll be able to work specific with those those sort of those patient groups.
And Andy, I thought the Can Rehab, aren't they? They're level 4, aren't they? That's why they're on the Can Rehab register. So I think,
Yeah, I think they're level.
I think that
They are.
yeah,
I'm
they're
just
level
jumping in.
4.
They are, yeah, definitely. As long as they're qualified, if they're going through the training. But yeah, if they've done Can Rehab, they're level 4.
Yeah,
Absolutely. And I think the two sort of licensed level 4 trainers at the moment are Can Rehab, and then there's the Right Foundation that are used in some parts of the country, aren't they? I think with WesFit, where the prescribed exercise was being taken on in the gym, we were beginning to look at whether it needed to be a level 4 doing all the work, or whether actually as long as you had a level 4 somewhere in the building, that would be enough.
Yeah, and I think the difference there was that the exercise program for WesFit was prescribed by us centrally, whereas with the Can Rehab instructors for SafeFit, they're personalising it. You know, we really just referring the patient, and then they're personalising it, so they need that extra level of skill.
Yeah, absolutely. Brilliant. Thank you both so much. Have we missed anybody? Has anybody else got a burning question now? Or can I just say thank you both? I have recorded this, but I know it's not easy for everybody to access said recording. But as before, I think both of you are happy that if I can share your slides, your presentations on the Wessex Cancer Alliance website. It's a closed website which people can only access through links anyway. So that's there. So yeah, big thanks from all of us. Lots of brilliant feedback in the comments box as well.
I'm happy to share email as well if people want to contact me to answer any questions after the meeting as well. If that, I'm happy with that too.
That's brilliant. Thank you so much. And I think this is just such a good opportunity when so many people are able to get together and look about, you know, like-minded people really being able to push this agenda forward. I'm conscious that it's 3 minutes to now, so everybody's probably got to be in another virtual room or elsewhere. I did want a bit of time just to get some feedback about how we move these webinars on, because we've had some absolutely amazing speakers. I know for next month we have got a focus on radiotherapy, and then for the June session we thought we'd go back. David Wright's going from the MSRG in Southampton is going to do some work around logic model and sort of service delivery. But please let us know, it's for you guys. So if there are things that you would like us to run or focus on, let us know. I did wonder about doing a sort of Dragon's Den without the wads of cash, sadly, but because we've got some really skilled experts that phone into these calls, and if people are thinking about setting up either a service or a trial, it might be an amazing opportunity to perhaps come and present what you're thinking and get some really good feedback, which might also actually support you in your business plan or proposals. So have a think about it. Let me know. Who's got their hand up? Somebody's got a hand up. Can't see. Juliet.
Hi, sorry, I've just got funding for a 2-year project for a physio, OT and assistant psychologist. So I'm just putting a program together. So I'd find that really useful actually to present the program and get some feedback from people. That'd be amazing.
That would be brilliant. So perhaps I can pick up with you outside, but we could link you into the June webinar. And we'll get you an expert panel round the table.
Perfect. Thank you so much.
Not at all. Can you make sure I've got your email address, which I must have, but
I'll drop you a line after this.
Great. Thank you. Okay, any more questions for anybody else? Thank you all so much for your time, particularly to Andy and Liam this time. Have a good rest of the week. Look, and perhaps Liam, we could get you back in a few months' time, just to once you started recruiting. And I know Zoe, your things are moving forward for you as well, aren't they? So I know that we'll hopefully be getting an update from you as well. Thanks, everybody.
Certainly, yeah.
Take care. Have a good rest of the week.
Thank you. Bye-bye.
See you, Anon. Bye.
Bye.